For those of you who don't know me, I'm Linda Cam. I'm the pharmacist at the ID pharmacist at the VA hospital. And today what I wanted to do is kind of update you on the immunizations for the upcoming year. I'm going to touch on influenza for the upcoming season. I'm going to touch on HPV, particularly in males, because we deal a lot with HPV or males at the VA, obviously. And then also the third thing I wanted to touch on was Zoster. Due to interest of time, obviously, I'm not going to be able to touch on other updates and immunizations, but I just kind of wanted to give you an overview of the three that I've mentioned. Just to kind of give you a little history of the first vaccine, some of you may recognize this nice picture. Edward Jenner, who's known as a father of vaccinations in 1796 from Berkeley, England. If you can kind of picture this, he's actually incising this lady, the lady's arm who was infected with cowpox, and what he was doing was he's actually taking the drainage out of the lady's arm and then injecting it into a little boy to prove that by doing that he was able to offer the little boy protection from smallpox. Subsequently, he also experimented with 12 different cases, and then 16 later on they found 16 additional cases that he's collected since 1700s. So obviously nowadays with IRB and R&D, none of that would ever happen, but this is kind of interesting how this whole phenomenon of vaccine evolved. So a book was published called The Inquiry into the Causes and Effects of the Variola Vaccine, and basically explaining that the cowpox protects the human constitution from the infection of smallpox, and therefore that's how the whole vaccine era evolved. Just to kind of give you an introduction into vaccines, about 50,000 to 90,000 adults die per year in the U.S. from pneumococcal infection, influenza, and Hep B. And as you know, these are diseases that are available in a vaccine. So these adults can be protected, but we have pitfalls in our vaccination system and our infrastructure to vaccinate these people. So there's areas for improvement. And even in children, 300 to 500 children die from diseases targeted by childhood immunizations. And there's been studies looking at why this is the case, you know, why nowadays they're getting a little more strict when kids enter into school. They have to have all those forms documenting their immunizations, but it's usually in the low socioeconomic class that we see that these children are not getting vaccinated and eventually die of disease because they have no access to some of those, the healthcare and the clinics that we have. Reasons for a poor immunization record: well, doubts about efficacy and safety of the vaccine. We have patients that refuse to get vaccinated because they've heard, you know, that it actually gives you the disease. So there's certain myths that we probably need to clarify for some patients. Uncertainty of the recommendations. They feel that, you know, do you give a series of 3 Hep B? What happens if they only get 2? Do you get the third? Do you start over? You know, some of those recommendations may not be very clear cut, and therefore you know, it puts the uncertainty in some of our patients. Liability reasons: inadequate reimbursement may be a hindrance for getting patients immunized, and poorly developed systems for immunization. I know even in the VA system, because we have electronic medical records, sometimes it's difficult to ascertain whether a patient has gotten the full immunization, because there may be gaps in when the patient comes in, and maybe they didn't show up for their number 2 of 3 series, and so you got to look at 3 or 4 different places to try to find the record, that sort of thing. Hypersensitivity to vaccines. You know, patients get a local or systemic. You know, with the influenza, sometimes they'll say, you know, my arm really hurt and it was so sore for a week, they didn't want it. Egg protein in production of some of those vaccines. Yellow fever, measles, mumps, influenza, for example. So patients who are maybe allergic to egg may not be eligible for the vaccine. And then certain antibiotics. There's actually some antibiotics in some of our vaccines. So if patients have allergies to some of these, they may not want it. And then preservatives like thimerosal or mercury or things like that, that's in some of our products, may hinder patients from getting vaccine as well. There's also some variability in their immune response when we vaccinate patients based on their general health. Whether we're giving them a live attenuated vaccine or a killed vaccine, and then the total dose. So as I alluded to earlier, if you've only given a patient 2 of the 3 on the Hep B series, they're not 100% protected. So there's some variability in how well we're protecting our patients. And then route and site of administration. You know, the flu vaccine, one of them is actually available as a mist, a spray in the nostril, and I'm going to go over that in a little bit. But, you know, is that more protective than the injectable? You know, there's I don't think the general public is very aware of that. So if you look at some vaccine delivery shortfalls in adults, in the literature, you know, they say 97% compliance in children greater than 6 years of age, but actually less than 2 years of age, there's less than 50% are being vaccinated. And there's very many missed opportunities. You know, at the VA, we still haven't gotten our influenza vaccine for this season, and there may be we originally thought there would not be delays because there's, I think, 4 or 5 manufacturers that are making the seasonal influenza this year. So we thought, well, we got 4 companies or 5 companies making it. But now I'm hearing it's not going to be here until mid-October, late October. So, you know, people that are coming into clinic now wanting it and we don't have it, and then say they don't come back for 6 months, well, that's a missed opportunity. So it's important that we encourage them that, you know, even though we may not have it, then they probably need to get it somewhere on the outside if it's available at Walgreens or CVS. And Medicaid actually reimburses. So basically for the patient, it's free, whether they get it at the VA or at CVS or Walgreens. So the types of immunizations that we can provide for our patients, actually there's different types. Vaccine, we can give them a vaccine, and the purpose of a vaccine is to induce the active immunity. And examples of this, we can give them a live vaccine, which is an attenuated. An example would be the polio or MMR, mumps, measles, and rubella. It can be a killed vaccine, which has been inactivated. So flu or influenza would be an example of that. Hep B and pneumococcus are all examples of killed vaccines. We can actually give them toxoids. So an example of that, which most of you are familiar with, would be tetanus or diphtheria is a toxoid form. It's not really a vaccine per se. Or we can give patients immunoglobulin, and that's usually if they come in, they've actually got the disease. We want to be able to enhance or activate their immune system rather quickly. So that's when we would give them immunoglobulin. And basically immunoglobulin are actually antibodies from donor pools. So you can get a CMV immunoglobulin, you can get rabies immunoglobulin, you can give herpes immunoglobulin. There's a whole list of immunoglobulins that you can give patients when they come in with an active disease. There's 2 types of immunity. You can provide active immunity, and basically what you're doing here is you're exposing the disease to the patient, and by doing that you're triggering their antibodies to be produced. And there's a natural immunity, so an example of that would be chickenpox, for example. You expose them to varicella, and therefore they are now protected from varicella. They may have the varicella with the chickenpox and the syndrome, but now they're protected after they get over that. Or you can actually induce the immunity by giving them or introducing a killed or weakened form of the disease through vaccination. So an example of that may be the zoster, because you're actually giving them a live attenuated vaccine to protect them against the zoster. And if persons come into contact with that disease in the future, their antibodies are protected. So if they've had chickenpox, they've had the syndrome, they've got the natural immunity. And normally it's long-lasting. It's a lot long-lasting than passive immunity, and in some instances it's lifelong. So in the old days when people said, you know, if you got a kid in the neighborhood that has chickenpox, well, bring your kid over. You know, they had like their chickenpox party. So everybody will get it at the same time. It's done with. They're protected for the rest of their life. Nowadays, because everyone's getting varicella vaccine, in adolescence and as a child, no one's getting chickenpox. So there's even been speculation that as we're vaccinating our children, they may need a booster. Is it 10 years? Is it 15 years? No one really knows. And now, if you've gotten the varicella vaccine, you actually have to have a booster by the time you enter 7th grade. Because mine just entered 7th grade and I had to bring her in for that. So now after her 7th grade boost, does she need another boost in 10, 15 years? I don't think anyone really knows yet. Passive immunity is preformed antibodies to a disease, and they're actually given to the patient. So an example would be your newborn baby. You're acquiring passive immunity from the mother through the placenta, or you're actually giving a patient's immunoglobulin because you're giving them passive immunity. The protection is usually immediate in this case. However, it's usually not long lasting. It lasts a few weeks to months, but it usually does not last a lifetime. So active immunity is the best way to protect our patients. So I'm going to that's kind of my intro and overview. I'm going to kind of go into each of these specific vaccines now. First, I'm going to touch on influenza. Influenza is an inactive vaccine from embryo, so egg protein, and that's why we said patients who are allergic to egg do not get this. And because of our antigen drift, every year we get a new strain or a new vaccine, because it's based on what strains are most likely to present in that season. It's an annual immunization because of the antigen shift or drift. And its recommendation for anyone at risk. And this year, I don't know if anyone have seen the newest recommendations, but the newest addition is pregnancy, and I think my next slide touches on that. But there's some discrete recommendations for this coming influenza season. Influenza, some people say give them the flu. They feel like they have myalgias and flu-like symptoms for a day or two, and it's not uncommon to have some of that. I always try to tell the patients it doesn't give you the flu, it may be just your body's reaction because of the injection. But it does not provide 100% immunity. And do the flu shots work? Well, this was an older study from 1995 out of New England Journal of Medicine, and Nickel actually looked at patients who were 18 to 64 years of age, and he looked at upper respiratory tract infections, days of respiratory illness, how much sick leave they had to take from work, and whether or not patients who were vaccinated actually did better than those that weren't vaccinated. And he kept a illness log of these patients. They were called and interviewed on a regular basis to see whether or not the vaccine actually works. So as we know, because now it's 2010, that influenza vaccine does work. We are able to reduce the incidence of upper respiratory tract illness. We're able to reduce the number of sick days or days that people had to take off from work because of a illness. And then also due to secondary illness, visits to providers and that sort of thing. And this is the newest recommendation for the season 2010-2011. One of the, I've highlighted the major changes here in yellow, is all persons greater than 6 months old is now recommended to get the influenza vaccine. So in your pediatric population, that's now a recommendation. Pregnancy is now recommended in the 2010-2011 season. And I think this American Indian Alaskan Natives came from last year's H1N1 because we saw a predominance of Alaskan Indians and or American Indians and Alaska Natives who had H1N1. I think what they did was they took all the cases of the H1N1 and then kind of stratified them, and they found that those sorts of patients had a higher risk. So now the newest recommendations are recommending that American Indians and Alaska Natives, that the new vaccine for 2010-2011 actually has H1N1 in it. So you know, patients are going to be covered. They don't need two separate shots. The seasonal influenza has H1N1 in it. Patients who are morbidly obese, it's recommended. Healthcare personnel, of course, all. And then household contacts or caregivers that are in close proximity or take care of those that are at high risk. So there's 5 manufacturers that are making the flu influenza vaccine for this year. And here are some names that you may be familiar with. The last one, the FluMist, is the inhaled one that I don't know. You guys probably don't use any of the inhaled here. Yeah, doesn't make sense. But in your pediatric population, you may see some of that. The VA does have the inhaled, but for the most part, we don't use too much of it. So those are 5 that are made. And these are, so it does contain the H1N1 for this year. It has the H3N2. I know that was a little bit of a question later on last year, towards the end of the season. I think there was a surge of H3N2, so that's in there, and then also the B is in there for this year. It's got the 5 vaccines I mentioned in the previous slide actually has a 15 micrograms of hemagglutinin protein. It does have thimerosal in it for this year, so any of your patients who may be allergic to thimerosal, they may need to go to the FluMist, the inhaled. And then, or if they have allergies to any of these antibiotics listed, polymyxin, neomycin, or gentamicin. And then all of the U.S. influenza vaccines are latex free, and that was a new thing because of the latex allergies. There was, there was recommendations by ACIP, which is American Committee on Immunization Practices, that we make all of the vaccines in the U.S. latex free. And to touch on the latex free issue, I don't know if any of you have been made aware of this, and this may actually be contributing to some of the delays we're seeing. What they found was the Sanofi Pasteur influenza vaccine, the syringe tip caps, they claimed that there was no latex, but after further study, the FDA found that there was some latex that was found on the caps, the tips of the syringe caps. So they had to go back, and now the FDA is telling them, because they have insufficient documentation to support their latex-free claim, they're making Sanofi Pasteur go back and provide additional documentation to support their claim that they're latex free. But what this has done, Sanofi is claiming that they're using the same process to make their other latex free syringe tip caps, and they've been using the same tip caps in these single dose pre-filled syringes since 2003. So the FDA is making Sanofi Pasteur go back, collect a whole bunch of data to prove that they are indeed latex free. So I think this may have contributed to a little bit of the delay that we're seeing in getting the influenza. Do you guys have it yet here? Not yet. Not yet. Okay.
By the end of the month, but
yeah. One thing that's changed a little bit this year, and I just wanted to touch about that, is elderly. You might be hearing or have heard about the high dose influenza. So I just kind of wanted to touch on this and tell you a little bit about the burden of influenza in the elderly patients. And this was published in JID 2006, and what they did was they looked at deaths and hospitalizations by age groups. So at the bottom there is the decade or the 5-year increment in their age, and the dark blue is the hospitalization and the light blue is deaths. And as you can see, as we age, our risk of or burden of influenza increases, whether it be death or hospitalization. So what someone did was they looked at that and they said, wow, that means that the elderly patients aren't being protected as well as the younger patient population. And why is that? Well, maybe because of declining humoral or cellular immunity, it actually increases the susceptibility to infection. Is it because of the magnitude and quality of the persistence of the antibody? And that declines over age. So is that why they're having reduced immunity? Are they having a decreased immunologic response to the vaccine? So you're giving, everybody gets the same dose, regardless of how old they are, how big they are, you know, how they eliminate drug. No one's really looked at that. So is it because they have a reduced response because they're elderly and they need more drug to mount a response? And the elderly adults are 2 to 4 times less likely to achieve protective antibody levels after we give them an influenza vaccine compared to young adults. So what they did is, same author, as you remember from 1995, now in 2007, they're looking at an older cohort. Now they're looking at anyone 65 years and greater, and this is over a 10-year period. And again, they looked at hospitalizations for pneumonia and the incidence of influenza. But rather than a randomized controlled trial, this was a retrospective chart review looking at patients in this age group. And what they found was, if you look at hospitalizations on the left and deaths on the right, hospitalization, we had a 40% I guess effectiveness of vaccine and reducing the risk of hospitalization was about 40% if we strictly look at the elderly patients. And this, and if you, on the right there, if you look at the deaths, there was the vaccine was effective in reducing the incidence of death in about 50-60% of the patients. So there's room for improvement, I guess, is what the conclusion of the study was. You know, we're able to reduce hospitalizations and we're able to reduce deaths, but we're not really where we really need to be, because this is a disease that can be protected by immunizations, and we're not protecting the elderly like we need to be. So that's how this high-dose influenza vaccine came about, and this is now available in the United States. It came on the market this year, and it's available for this coming season, 2010-2011, and it's recommended for anybody who's 65 years age and older. It's the high dose, it's called a Fluzone or high dose. So there's 6 products now for this coming year that's available. And I wanted to share with you, I know, you know, you're probably going to talk to the drug rep, or you're going to try to talk to, you know, people are going to come up to you and say, I want it because, you know, I'm elderly and I think I need it. But I just kind of wanted to make a couple of points. Yes, the high-dose inactivated influenza vaccine is 4 times the amount of antigen as the standard inactivated vaccine. It has been demonstrated to be safe, and I'm going to review a little bit of the safety data with you in a minute, but realize there are more local reactions. These patients are going to get more pain at the injection site and erythema at the injection site, and that's been reported as well. And that on the right is just a comparison of the high dose versus the low dose, with human agglutinin inhibition on the top and neutralizing antibodies on the bottom. And as you can see, the dark color, which is the high dose, is definitely more likely to create a response with the, if you look at human agglutinin inhibition and neutralizing antibody. But we do see more pain with the high dose, 36%, versus the standard dose at 24%. Erythema is more likely with the high dose, and then also swelling is more likely with the high dose. And that's just a breakdown of what I've just said. So, in summary, with the high dose, it is shown to be superior to the standard dose for those 65 years and older in looking at human agglutinin inhibition and neutralizing antibody, and the proportion of patients that are successfully immunized. What we don't know is we don't know what the outcomes of these patients. We don't have that data yet. We also know that the high dose has more side effects, more incidence of side effects, but we definitely don't have data on efficacy. We don't have any outcomes data. We don't know if those elderly, yes, they're mounting a response, but are they getting more hospitalizations from that? Are they getting less hospitalizations from that? Are we reducing their death rates with the high dose? We don't have that. And as of last week, the CDC and ACIP still have not endorsed the high dose. They're kind of letting you make the decision. They're not making a very clear-cut recommendation on, everybody 65 and older should get the high dose. They haven't made that statement yet. Any questions or comments on that? Okay, I'm going to go to our next vaccine, and it's the Herpes Zoster vaccine. This been out for a few years. Some of you may have already had some experience in using it. Our VA was actually one of the sites for the study when this was started, 1997, I think. Does that sound about right? 1997. So we've had the luxury of working with some of our patients who were in the study. So herpes zoster, shingles, it's caused by varicella zoster virus. We get it as kids, and we know it as the primary infection as chickenpox. And what happens is the virus stays dormant in our body because we make antibodies to suppress the virus. But as we age, or if we're stressed in our lives as we get older, what happens is it reactivates and it causes shingles. And it's manifested as a painful rash in a single dermatome usually. It doesn't cross the midline. And that's kind of a classic zoster, although you can get disseminated cases, of course. The rash usually crusts over, the fascicular rashes usually crust over and dry up and resolve, but what happens is you get some complications. You can get some complications from the zoster, primarily post-herpetic neuralgia, which is pain that can last for a long time, weeks to months and even years. To that area where you had the rash. It can be a very devastating type of pain. I've had patients say, it hurts to even put on clothes because the clothes touching that area hurts. And then other things like ophthalmic involvement, bacterial superinfections in that area. We've had few of those cases. Cranial and peripheral nerve palsies because it's a herpes virus, and visceral involvement. So these are all complications from the zoster. So the zoster vaccine is a live attenuated virus. It's used to indicated for prevention herpes zosters in patients greater than 60 years of age. Overall efficacy, it gives you a 51% reduction of herpes zoster, 39% reduction of post-herpetic neuralgia. And what we found in the study was efficacy in the prevention is actually higher in the younger age group. So our patients are stratified into two groups, 60 or 70 or greater than 70. And what we found was the younger 60 to 70 group actually had a higher protection or prevention rate. The dose is given as a 0.65 ml 1 vial sub-Q. A little problem with this vaccine is it has to be frozen, and you have to give it within 30 minutes of reconstitution. So, if your hospital is going to use it, they need to have it, practically the freezer right there with the patient, because the nurse will pull the vaccine out of the freezer, reconstitute it, and almost immediately have to administer it. You can't wait for the delivery up to the hospital or down to clinic or whatever, because it's a live attenuated virus and it has to be kept frozen. And we don't know if a booster is needed. Right now we are about 13 years out from when the first set of patients got vaccinated. Some are speculating that they will need a boost in 10 years, because what we're finding is we have a long-term persistence study where patients have been calling us for the last 13 years after they've been vaccinated. And what we're seeing is some of those patients that were vaccinated early on are now presenting with perhaps shingles. So we don't know where this is going. Merck is actually analyzing all of that data right now, but some are speculating that you will need a booster in about 10 to 15 years with this one as well. Contraindications with this one is it's in immunocompromised patients because it's a live attenuated virus. So you don't want to give in your immunocompromised patients, patients with active or untreated TB, pregnant, or anaphylaxis to neomycin or gelatin. Should not be using this one. And then the last vaccine I wanted to talk about was for HPV. HPV is transmitted sexually. We know that about 50% of the women who are sexually active by 18 years of age have it already or has been exposed to it, and 20% who have greater than or equal to 4 sexual partners are likely to have gotten it. 98% of the women are sexually active by 25 years of age have had it. And it's the most common viral STD. There's about 6.2 million are infected with HPV each year, and 80% of the women are infected by the time they're 50 years of age. It's usually a disease of the young, less than 25, or it kind of dips down in your midlife, and then it kind of peaks again once you second peak at about 45 years of age. So and it's highest risk within the first 5 to 10 years of sexual activity. So obviously for this vaccine we want to maybe target, you know, the younger group who are sexually active. The clinical manifestations of HPV, there's actually about 100 different types of HPV virus, only of which 40 are affect the genitalia or genital tract. Genital HPV usually presents or is manifested as genital warts, or it could be manifested as a malignancy in the cervix or that sort of thing. So it usually is in the vaginal mucosa, in the cervix area. Risk increases for persistent infection, and that's why within the first 5-10 years of sexual activity, or if they've had multiple sex partners, they're probably at a higher risk. Leading cancer in developing countries, cervical cancer is, and second most common cause of death from cancer in the world. And then HPV can affect the penis. 50 to 70% of penile cancers are secondary to HPV as well. So the types that the HPV vaccine really targets at your genital warts. 90% of your genital warts are caused by types 6 and 11. Remember we said there's about 100 types, but of those 40 of them actually are related to genital or STDs. And then cervical cancer are caused by HPV type 16 and 18, and anal genital cancers are caused by 12 and 13. What I want you to remember is probably the first two, 6, 11, 16, and 18, because as we go through the next several slides, that's going to be helpful. So if you look at the classification of cervical pathology, I actually want to start at the bottom. And CIN is cervical intraepithelial neoplasia. And remember those strains that I mentioned in the previous slide, 6 and 11 there in the middle? If they have a CIN class 3, they usually do not present with genital warts because it's usually affected by strain 16 and 18. Okay, and other strains, the other 30-something strains that we didn't really talk about. Same thing with CIN2 classification. These patients usually present with moderate dysplasia. Again, they're usually not affected by strain 6 and 11, but they are affected by strain 16 and 11. And then your more mild cases, patients with CIN classification 1, these usually present with just very mild dysplasia. These, on the other hand, are affected by strains 6 and 11, as well as 16, 18, and all the other strains. And then your classic cervical condyloma patients, they're usually caused by strains 6 and 11 and not so much the other strains. And why this is important is because there's 2 products on the market and they actually work against different strains. So one product may work better for things that are affected by strain 16 and 18, and the other product may work better for strains and different levels that are caused by strains 6 and 11. And I'm going to go over that here. So these are the 2 products that are on the market. The first product that hit the market was Merck's product 2006 called Gardasil, and it has activity against all 4 strains. It has activity against 6, 11, 16, and 18. So essentially it will probably work against your CIN 1, 2, and 3 because it has activity against all 4 strains. This is given as a IM injection, and it's a series of 3 shots, 0, 2, and 6 months. And now it's indicated in men as well. So originally when the product came on the market, it only had the indication for women, but most recently it's got the FDA indication for men as well. So you can give this in men. Duration of efficacy is about 5 years. The other product that's on the market, this came out last year, GlaxoSmithKline's product called Cervarix. It's only a bivalent vaccine and it only has activity against 16 and 18. So it's probably not going to protect in your condyloma type patients because it doesn't have activity against 6 and 11. This is the more popular product. Several reasons. It's got the indication in women and men. It's got activity against the 4 strains. I think when this product came on the market, their claim to fame, if you will, is it contains an immunostimulatory adjuvant, which potentially increases immunogenicity. So that's what they've been really marketing it against. You know, we've got better immunogenicity. If you use our product, you're more likely to mount a response than our competitor's product. And if you look at the duration, it's about the same, 5-6 years for both products. We're just starting to use the quadrivalent at the VA in our male populations. Prior to that, we had kind of a protocol in place for our women. You know, they had to be of a certain age and that sort of thing. If you look at efficacy rates with the HPV vaccine in your HPV naive patients, it's about 90 to 100% prevention. So it's rather high. In your high-grade cervical lesions with the type 16 or 18, you know, it's moderate. It's not as good. And then high-grade cervical lesions from any biotype or any type is only about 17%. So you're going to get, I guess, the most bang for your buck, and that's what we looked at the VA in your HPV naive patients. And who are those? Those are going to be the younger, they're not sexually active yet. And that's why I think now, even in adolescence, you know, they're really pushing that. If your child is a teenager and they're not sexually active yet, that's when you need to give them, because you can't wait until, you know, they get older, because your efficacy rate is going to drop off, and that's probably not when you want to offer it. So looking at women who's greater than 26 years of age, there was one study published in Lancet last year, and they strictly looked at women who were older women. They found 100% seroconversion, and they were able to show that it offered immunogenicity in uninfected women. They actually boosted it actually, by giving them the vaccine, they were able to boost the immunity in those with the low titers. So they thought that was beneficial, and it provided protection against type 16, 18, and seronegative women. However, with the limitations in or a little bit older in the mid-age or second decade of life, benefit of HPV vaccine decreases as the woman ages. New infections usually do not progress beyond the CIN2 classification. So usually it's, you know, they don't usually progress beyond that. It's the elderly patients that get that. And the studies only examined 7 years after the vaccine, so the study was limited by that because, do you need a booster after the 6 years was up? And they stopped at 7 years, so we don't know if there's been long-term follow-up of those patients. They did not substantiate the cost effectiveness of this vaccine. And right now it's not approved for women greater than 26 years of age. But there is the study out there, and I just kind of want to mention it if you hear about giving it to women who are greater than 26 years of age. Adverse effects of HPV, you probably heard lots of this. There was a lot in the media and about, teenagers passing out after they got the vaccine. So as of May 1st, 2009, there's been greater than 13,000 ADR reports reported to the CDC from this HPV vaccine. 7% of those were considered serious, and the highest number of reports were between the age of 11 and 18 years of age. Some of the side effects they experienced were mainly pain, swelling, erythema, headache. I guess syncope was the one that got the most attention of the media and things like that. And what they found was it was more common when the girls were given DTaP, diphtheria, tetanus, excellular pertussis at the same time. They were more likely to have the syncopal episode. Nausea, and then venous thrombo event, 90% with known risk for DTEs, and then fever, about 13% of them developed a fever. So this was, it hit the newspaper, the headlines, that these girls are passing out after they get the vaccine. So what the ACIP is recommending now with HPV is you should offer it to girls between the age of 11 and 12, because of some of the things we mentioned, and even as early as 9, which is very scary, I think. But surveys and multiple studies have shown that the kids are now being sexually active at an earlier age, so that's why I think ACIP came out with this recommendation. It's also recommended that if you give the vaccine, you need to wait 15 minutes after vaccination to observe for syncopal events, especially if they're in that age group, 11 to 18. If you're going to give it with HBV, it's recommended that the HPV be given at a separate site than HBV. So, separate arms. And then avoid in pregnant or breastfeeding women. There's actually a pregnancy registry that the pharmaceutical company is keeping tabs on. So if you look at the risk versus the benefits and you want to offer it, then it's recommended that you register your patient with the pregnancy registry with the company. Or first option would probably be the best. Finish a series after the pregnancy. So if the 3 shots, you started the first and then they become pregnant, then just wait and finish the 2 later on. And then the ACIP highly, I guess I should have bolded that at the bottom, but routine cervical screening is still required. It's still recommended that they get their annual pap smears, because I think the public perceives this as, okay, I got vaccinated and it's smooth sailing from here. I'm never going to get it. I don't ever need a pap smear or pelvic exam again. So I think our job is to kind of get that message across. It's important you get it. It prevents, but it's not 100%. There's certain things it protects you against, but it doesn't protect you against everything. And remember, I said there's 100 different serotypes out there, and we're not protecting the majority of them. And then just to touch on HPV in males. In males, if they present with HPV, it's often asymptomatic. Unknowing transmission between men to women. There's not really any rates out there that I was able to find between men to women versus men to men. And transmission is not necessarily prevented by condom use, so that's very important too, because they could be shedding the virus and actually infecting. In males, it's 89% effective in preventing genital warts. Again, it's associated with HPV type 6 and 11, and about 80% effective in preventing infections from HPV type 16, and about 96% effective for preventing HPV type 18. So about the range between 80 to 95%, I would say, in your 4 most common types that cause HPV in males. And that is about it. Do I have any questions or comments or